My name is Matt Jones and I'm presenting an electronic algorithm for the management of carpal tunnel syndrome along with a one-stop surgery pathway. Carpal tunnel decompression has controversially been labelled a procedure of limited clinical value. This has led to the evidence-based intervention guidance. This national guidance has been incorporated into local commissioning policy and highlights when surgery can be offered and requires the completion of additional paperwork to ensure it can be funded. Since this hit the headlines and since this document was published, there's been a misinterpretation of these recommendations and an increased variation in practice, leading to delays in referrals, inappropriate steroid injection, and worse patient outcomes. This was highlighted in our one-year retrospective review of referrals, noting 23 patients having more than one steroid injection prior to referral, and 19 of which having permanent sensory changes in clinic, and 2 of which having permanent sensory changes post-operatively. We designed a clinical pathway for primary care clinicians seeing patients with probable carpal tunnel syndrome to guide the assessment and treatment in line with national guidance. We use OrthoPathway, a web-based application designed to host editable decision support pathways as a platform for this. The pathway takes the end user through 3 stages where the answer at each will determine the course of treatment ending in one of 5 outcomes. The national EBI guidance has been incorporated within this pathway. The outcome from OrthoPathway allows streamlining of referrals so definitive decisions can be made on initial presentation, be that conservative treatment, nerve conduction studies or surgery, therefore reducing face-to-face appointments and referrals for additional tests. As a proof of concept, we carried out a one-year retrospective review of referrals to establish the scope of the problem, to aid in service planning and determine potential clinical and cost savings. All new hand and wrist referrals to Barnstable Hospital over a one-year period were included. Clinic letters were used to confirm a diagnosis of carpal tunnel syndrome, and the GP referral letters used to confirm carpal tunnel syndrome as the reason for referral. Clinical findings from the clinic letter were used to determine the OrthoPathway outcome, and this was compared to the actual patient's journey. 144 patients were referred from primary care. 75% had an uncomplicated diagnosis, meaning a diagnosis could be made from clinical examination alone. We had an 81% conversion to surgery, and 49% was suitable for one-stop surgery. 62.5% of all patients had nerve conduction studies. 55% were prior to referral to secondary care, of which half weren't clinically indicated, demonstrating a potential reduction in referrals by 23%. 184 appointments were generated for these carpal tunnel syndrome referrals. If the streamlined outcomes produced by OrthoPathway were used, this could be reduced by 82%. A reduction in cost of about £60 a patient was determined as part of a wider, commissioned health economic analysis of OrthoPathway as a whole. This can be extrapolated as a potential annual saving of £16,000 across the CCG. The use of this electronic algorithm has the potential to reduce face-to-face appointments, need for additional investigation, reduce costs in a manner that is safe, as no patient would have been incorrectly referred for one-stop surgery.